Hi, everyone. Thanks for joining us to learn about our study entitled General Purpose and Reasoning Large Language Models for Automatic Abdominal CT Protocoling. My name is Andrew Chung. I'm an abdominal radiologist at Kingston Health Sciences Centre and Queen's University in Kingston, Ontario, Canada.
And I'm Ethan Sacoransky. I'm a PGY1 diagnostic radiology resident at the University of Saskatchewan in Saskatoon, Canada. And most of this project was completed during my final year of medical school at Queen's University, as well as during my transition into residency.
So this project began with a simple but important question. Radiologists review hundreds of CT requisitions weekly, selecting protocols, contrast use, and priority. These are high-impact decisions, but also highly repetitive and time-consuming. With large language models like GPT-4o and OpenAI's O series becoming more accessible, we asked, could we automate parts of this task using site-specific protocoling guidelines? So Ethan, do you want to take us through what we did?
Sure. So we conducted a retrospective study. We looked at 300 real-world abdominal CT requisitions. These were all from April 2024 from Kingston Health Sciences Centre. And they were not simulated cases. They were not synthetic data. They were real requisitions issued across outpatient, emergency room, and inpatient settings. We were able to de-identify the requisitions and extract relevant data such as clinical indication, allergy status, and renal function. And two abdominal radiologists were able to independently review all the cases to establish a reference standard for protocol, priority, and contrast.
And the reason for that is that at our site, protocoling is done by a range of individuals, including trainees and sometimes by cross-covering staff, which can lead to some variability. So we chose subspecialist consensus to serve as the most reliable reference standard for protocol.
And we chose to evaluate three artificial intelligence models, GPT-4o, O1 Mini, and O3 Mini. And we decided to use a standardized system prompt. Each model received the same hospital institutional protocoling guidelines and few shot prompting examples. These AI models were asked to return four outputs, being protocol, priority, IV contrast, and oral contrast. And we then measured agreement with the reference radiologist gold standard.
So in our study, all three models performed well. The top performer, O1 Mini, achieved nearly 88% accuracy for protocol selection, 83% for priority, and over 91% for both IV and oral contrast.
The differences between the AI models were fairly minor, less than 1.5 percentage points across the various tasks, and even the smaller O series models held up very well against GPT-4o.
And importantly, none of the models made any unsafe recommendations. In particular, for instance, they never suggested IV contrast for patients with poor renal function or a known contrast allergy.
And the cost to run these models was low, around 27 cents US for the US model or for the O series models, and just over $1 for GPT-4o. And this could scale affordably across larger healthcare systems with a significantly larger number of requisitions.
So where we did see errors in the model, usually this was in underrepresented or complex protocols like angiography or multiphasic studies. These areas could be improved with more targeted training examples, we think.
And many of the remaining disagreements we found happen in cases with more than one defensible option. For example, some adrenal studies could reasonably warrant either a full protocol or a simple single phase scan.
So this brings us to a key idea that the automation itself doesn't have to be perfect. If an AI model can safely handle 85 to 90% of routine cases, it's already a huge win in terms of efficiency and workload reduction.
This also allows radiologists to focus their attention on edge cases that require clinical nuance while streamlining the bulk of day-to-day routine requests.
And remember that the models that we tested in this study were general purpose LLMs. They weren't specifically trained for CT protocoling. So we expect that purpose-built models in the future, or those fine-tuned on real-world data, will eventually outperform them.
A doctor in the loop system, meaning a workflow where radiologists review and confirm AI suggestions before anything is finalized, could help in the future to ensure safety, for triaging edge cases and building trust. And over time, we believe that these interactions could guide future model development.
So we really see this study as a foundation. It shows that even without specific customization, LLMs can meaningfully support radiology workflow when paired with a robust guideline-based prompting.
Therefore, in summary, large language models guided by institutional CT protocols can accurately and safely automate much of the protocoling process.
And so while, eventually we may see models that can handle even complex protocoling tasks and approach 100% accuracy, currently, the current models have strength even in just offloading routine decisions and reducing kind of that burden of protocoling. That alone would help reduce interruption fatigue and allow radiologists to focus on higher value clinical work or only have to look at, the most specific kind of difficult cases.
And in the future, doctor in the loop systems where we tie radiologist opinion with AI, with better fine tuning, we think that this type of automation could become a very practical and scalable solution for CT protocoling.
That's all we have. So thanks for watching. You can find our full article on NAJR and our code is available on GitHub. So we would welcome your feedback and any collaboration.